A very good afternoon, hello, and welcome all the viewers across the globe of the Vertical Views. Today, we welcome back Professor G. Suha on the request of the viewers who wanted to hear more and learn more from Professor G. Suha about the UV technique in cervical discectomy and foraminectomy. Last week, we discussed about the past, present, future of the UV technique in lumbar discectomy and decompression. Today, Professor Ha will be talking on the tips and tricks for beginners for UBE technique for posterior cervical foraminectomy and discectomy with the surgical demonstration of the videos of the technique. As we all know, Professor Ji Suha is chief of the division of the spine surgery at the Yonsei Oke Hospital. He is a celebrated neurosurgeon and one of the founding members of the UBE Society. He sits on many societies on minimally invasive spine surgery as well as neurosurgery. Last time, just a quick recap, we discussed about the past. We'll go a very quick review. In 1983, Professor Pervez Kambian, Iranian-American surgeon who was one of the front runners in minimally invasive spine surgery and endoscopic surgery, gave a publication on percutaneous lateral discectomy and fusion in 1983, followed by various publications across 2 decades in 1996 by Anthony et al., by Abdul Ghaffar et al. All the works and the work of the Ghaffar et al., Anthony et al., Park et al., Soliman et al. Has led to the foundation of the current UBE work. Last time we discussed about different techniques, tubular versus uniportal versus UBE. We discussed about the restriction of range of motion and the vision associated with the tubular and the uniportal technique. But we also discussed that any good surgery done with any good technique is better than badly done surgery with either endoscopic or UBE. We discussed the advantages of UBE, including it's water-based, contains irrigation-based surgery, which helps in reducing the blood loss. It helps to separate the layers with the water flow between the ligamentum fleum and the dural sac and the soft tissues. We also discussed about the minimal invasive surgical advantages. We discussed about the upcoming HR arm, which could be used in adult and pediatric deformities, high recesses, or benign tumor cases, and combination of navigation and UV techniques in the future. Now coming to the cervical approaches. Since 19th century, the first approaches discussed were cervical posterior approaches. They were commonly used for neoplasms as well as spot spines and infections. As spine processes are pretty much palpable from the posterior approach, so advancement of the posterior cervical approaches were quite common and was commonly used by the spine surgeons. Skadley et al. In 1949 first reported C6-7 disc herniation of a patient presented with the tricep weakness, first 3 fingers numbness and weakness, and severe muscle atrophy. They presented that they removed the disc and did the posterior decompression in 1949 and published the 16-year follow-up of the same patient. Although the posterior approaches of that time in 1950s and 60s were quite invasive in terms of the muscle damage as well as the destabilization associated with the posterior approach. Considering that spine surgeons moved from the posterior surgery to the anterior surgery, in 1950s, Robert Robinson and George Smith published and reported the Smith-Robinson's approach and led to the foundation of ACDF surgery. Over 4 or 5 decades, ACDF was the standard of treatment in terms of giving great clinical outcomes. Although in 2007, the posterior approach with the tubular as well as the endoscopic surgery came up with its own advantages. In 2007, Rutten et al. Published their full endoscopic cervical posterior foraminectomy and safe and good clinical radiological outcomes. Followed in 2017 first time the UV was utilized in the posterior percutaneous endoscopic foramenectomy and discectomy with great results. The current literature and a lot of publications are also available in the UV technique, uniportal technique, and tubular technique. Last year, Professor Ha published about the biportal endoscopic posterior foramenectomy with the UV approach. We'll come to know more about the technique, how it does it, the posterior cervical foramenectomy and discectomy from Professor Jisoo itself. We welcome Professor Jisoo for the further proceedings. Thank you.
Good afternoon, viewers of the Butterfly Show. It's my great honor to be here again and introduce me again. So, especially thanks Dr. Raj and Srinini to make this great conference during the lectures and some discussions tonight. So, today I'll talk about just for beginners, the bipolar endoscopic posterior cervical discectomy and foramenectomy. So I will show you some pictures and videos, and I will tell you some tips or tricks and pros and cons about these techniques. So, yeah, Dr. Raj gave us a good explanation earlier, but I will explain a little bit more about the endoscopic cervical history. So in the early 1940s, the posterior approach to cervical disc was first reported, as Dr. Raj mentioned. So, but it was a time when enormous pain after the surgery, when muscle spasm and loss of rhodosis were not overcome. Then microtubular foramenectomy was introduced in the early 20s. So, and the uniportal foramenectomy is also published in 2007. Finally, paper about the UV foramenectomy was published in 2017. So it's a relatively short history of endoscopic surgery of UVE. So at first, we think about that. Why we should do a cervical foramenectomy or discectomy, not ACDF. This is a very interesting paper. So the foramenectomy group has a much larger and a more effective degree of lumen expansion after surgery compared to the ACDF group. So that's why I always emphasize posterior foramenectomy has better result than ACDF or ADR for just unilateral foraminal lesion patient. So, and this paper also shows us that PCF is a preferred modality than ACDF for the the unilateral foraminal stenotic patient. So, if you choose the posterior approach, I know you are concerned about the possibility of the facet injuries, kind of disruption or post-op instability or kyphosis. But you don't have to much worry about that because if you have less than 50% of facetectomy, it will be okay. It is safe. All the articles are say like that. So then why should we do UV cervical foramenectomy or discectomy? Because it's very safe and because it's very good for ERAS, the enhanced recovery after surgery, kind of less bleeding and minimal muscle damage or something. And the patient recovers so quickly. So unlike the unipolar, the bipolar surgery in particular has no limitations in scope and varies in instrument. That means it guarantees easy access to a target point whenever you want to go, whenever you can do it. So based on the Spino's process, there is two types of the approaches. Performing the surgery on the region side is we call the ipsilateral approach, and performing surgery on the opposite side is we call it a contralateral approach. So look at the contralateral approach pictures. So naturally, contralateral approach creates an oblique slope of the inserted instrument and the scope. So which is also we call it inclinatory approaches. So let's look at the pros and cons. The ipsilateral approach is no different from the normal conventional microtubular surgery. It's familiar to surgeon. And the advantage is that you can cut facet bones vertically. So it means a wide decompression is very possible, but it also means more facet disruption is occurred on the other hand. So therefore, it is good to resolve lesions of the medial foraminal area. On the other hand, the contralateral approach proceed the obliquely, like this picture, so making easier to operate to the lateral foraminal. Now, in conclusion, I choose always the ipsilateral approach for the discectomy and the contralateral approach for the foraminotomy now. So although it's a paper from full endoscopic foraminotomy, but neither microtubular nor UBE will not be very different. Start at the pre-point and extend upward and downward and laterally, 3 to 5 millimeters. So why does foraminotomy have an advantage with the contralateral approach, not a discectomy, for the foraminotomy? This paper is very good cadaveric article. So according to this, you need to go at least 7 millimeters from the axilla to horizontally to achieve certain decompression. So, but removing facets close to 1 centimeter can occur in instability, you know. So how can we make 7 to 9 millimeters horizontal distance without excessive faster disruption? That's answer is contralateral approach. If you do the oblique, the facetectomy with contralateral inclinatory decompression, you can make effective foraminotomy without excessive facetal disruptions, like these pictures in the articles. So this should be easier to understand. Let's suppose there is a region that we have to do foraminotomy. The oblique approaches from the contralateral side can reduce facet disruption as much as possible, like this. If you do the look at the yellow area, if you choose the ipsilateral approach, the facet will be more excessively removed. But if you choose the contralateral, the inclinatory foraminotomy for the just foraminotomy, so it will be more save the facets. 25 to 50% of unnecessary facetal damage can be avoided. Like this. So let's talk about the entry point of the foraminotomy. For the ipsilateral or contralateral is the same. I always find the V-joint first. If you find the V-joint and put the fingers on the V-joint, and you can make two incisions around the V-joint, like these red lines. So if you the incisions length is 1 centimeter or 7 millimeters is both enough, but I recommend it for the beginners. Make more than 1 centimeter, so it will be more easy to do a surgery. So the cervical spine needs to enter through a lot of muscles. You know, the cervical neck muscle is more dense and so many muscles than the lumbar area. So it's better to use a serial dilator for the beginners. If you don't go to midline, when you put in the guide needle, so the root will not be hurt. So don't worry about that because the facet is coronally posted. So it blocked the needle way. So dura or nerve roots are very safe from this needle. So insert the entire leader slightly outside of the V-zone in the CM image like this, and then insert the serial cannula like this. Before the insert the serial cannula, you have to make some more fascia and muscle cutting so more deep and deeply. Now make more fasciectomy as deeply as you can will make this surgery more easy. Cannulas in and shake it or sway. I always said is a cross motion. So if you cross motion the closely move the cannula, then the holes of the muscle, the pathway is more wider. You can make it. So after that, you can finally see the waters comes out. So waters very well coming out. It means water flow is continuously well maintained. So you, as I told at the lumbar surgery, at the UB surgery, the outflow of the water is very important, because if the outflow water is not well, the water accumulated in the peridural area, so the ICP will be very elevated. So it's very dangerous situation. So we have to very focus on the outflows. Okay, as from the before the laminectomy, we are thinking about the relatively safe areas. So from the SESTA view, lower laminas, upper reach, where the empty space around the root axilla area. So it's much safer area, the blue line. So I always recommend to start from the lower level laminas. And coronally, the root proceeds in parallel with the lower margin of the upper level lamina. So the medial is more safe. So combine this, and when the two RSA, the relative safety area, are combined, the V to the midline is the safest way, the point of the starting point. The direct approaching to the lateral space for region is dangerous. So because the root passes through a relatively small space. So starting point is the region, and start from the upper margin of the lower level lamina. Don't forget it. And for discectomy, go to the medially, and for the frontomy, we can go to the laterally. So I show you some cases and videos. This is a patient, 57 years old woman. And he came to my office with a symptom of left upper extremity radical pain. There was so severe pain, and accessorily she has a neck pain and hand tingling sensations also. So from the July 19th, she did so much block, so much procedures, but it doesn't affected long. So I checked the MRI, and you can see the left side. You can see the discs on the left recess area. You can see that is a very big one. And at the Saturn image, also you can see the C6-7 protruded and extruded discs and compressed in the root so severely. Also, I checked the CTs. There is no severe bone so calcified disc. And this is a myelo MRI, and you can also see the very compressed nerve roots over there, here. So let's see how is surgery. It's not. Yeah, we at the first beginner stage we always show the red flags at the first time, but keep calm and do just the breathing control and try to make a water chamber for the surgery, and then after meticulous breathing control, we can see this clear view. So can you guess where is V joint is? This is the lefty ipsilateral approach. So right ipsilateral approach. So this is a C7, this is a lamina, and there is a lamina. So here is a V joint. Sorry, it's a left side approach. Yeah. So C6 and 7 lamina is appeared, and between them, the V joint is also we can find. And before the drilling, I always remove some facetal soft tissues, cover the facet. And the circle one is a V point. And if I have to do, this patient is a discectomy, so I will going to the medially. So that is a region. I'll do the drilling soon. Here comes the drill. As I told you, I always drill the lower level lamina first because it is more safe. If you drill the laminas a little bit more, you can see the empty space here. There's no root. Root is more upsidely going out through the foramina, and then you can remove more laminas, and the 5 o'clock area is a pedicle, and you can see also the C7 root is going through the foramina, and here is the axilla area. Then I use a hook and remove the ruptured disc like this. It's a kind of disc with epiphyseal rim. I mean the very hard type of disc. The disc was so bigger than I expected, so I want to do more laminotomy for the check the remnant disc particles. After that, I found one more particles of the ruptured disc, and then inside, medially, there is one more particles of ruptured disc. So if you do the pediculotomy, when you do the ipsilateral approach, it provides us so wide space for doing something. So a wide bone walk, it makes more easy surgery to us. So don't be hesitate, remove a little more bone removing. So you can see also the annular defect area. So complete decompression was done, and I show you some bonus track. If you want to do the foraminotomy also, you can go more laterally from the V joint. You can see the IAP and SAP here. More a semicircular movement of the drilling is more safer with a diamond drill. And the punch, meaning less than 2 millimeters, small punches are very useful tools. I don't recommend using of the more than 3 millimeters large punches because punch can make compressive injury to the nerve roots. So use a small instrument for the safety of the nerve roots. So like this, follow the nerve root, and you can go more laterally and finally you can achieve the lateral decompression. I mean the foraminectomy. It's possible. It's a post-op MRIs. You can see the full removal of the discs in the axial, also in the sagittal area. So this is another case. This is a very huge paracentral and down-migrated disc ruptures patient. Actually, with this patient, we usually think about the ACDF or the ADR, the anterior approach, but by the UVE, we can do this migrated disc rupture patient with endoscopic surgery or posterior approach. So this patient also has a left upper extremity radical pain with some weakness, grade 3. So I checked the MRIs, and this is our same patient. Look at the left upper, the pictures, the orange one. You can see the disc is paracentral disc. The cord is severely compressed, and I think if I did the surgery, the dural traction, a gentle dural traction would be needed. And look at the lower picture, the red one. There is another disc, the downward migrated disc is also this patient had. So more extensive foramen laminectomy will be needed for removing that disc rupture particles. So let's see how did I search for this patient. And after laminotomy, you can remove the axillary area, the disc rupture particle at the axillary area. This is a ruptured disc. So many discs, like a lumbar surgery. So, this patient has no foraminal stenosis, so we don't need to go to laterally. It's just enough to go just to the pedicle area. And disc removal at the axillary area is effective. And this disc particle is stopped and never going out with my with my forceps. So I did a little bit more extensive laminotomy for removing the downward migration discs. And after the extensive laminotomy, and finally I can remove the particles. But there is one more particles. I can see it. That is a real down migrated, separated disc particle. So gentle hook. I remove it very slowly. Safety is, the safety is a most important thing. So do not hesitate or something. Just take your time, and you can finally remove all the particles like this. Or paramedial disc removal was achieved like this. So many discs. Yeah. So finally I can check. I could check the annular defect area. So you can see the wide laminectomized site over the roots. So post-op MRI images shows the red one. Red one, you can see the center images. Red line means it's normal foraminectomy or discectomy line. But for removing the downward migration disc, look at the white, the gray line. That is what I did to this patient for removing the down migrated disc. And this is third case is and this time is we have to look the contralateral inclinatory approach. This patient is a right upper extremity radical pain also. And let's see. I think there is not many chances to see the whole decompression videos, so I made a so long take of the video for helping you guys. So I think it will be very useful and very helpful to you. After drilling of the perennial limb, you can see that the thin lamina is thin. There's a central cord and there will be a foraminal area. So as you can see, the inclinated foramina is less faster injury. It's an undercutting techniques. So we never make a full facetectomy. It's just a drilling and make a tunneling for the nerve roots. You can also use some cuirass like this. And you can see the point of the ligament fibrin is detached from the bone. And when after the removal of the ligament fibrin, you can see the extinct nerve roots. So it's a chisel. You can use all the instruments that you can use in the conventional surgery is a very powerful advantage of UBE. So it's a curved chisel for the SAP and IAP removal. You can remove the tips of SAP with a QRS for compression of the foramen area. That is a tip of the SAPs. You can see the external roots are going through the foramen area. Actually, nowadays I use more drills than this video. This video is truly is my early stage of the operation. Because why I did so this one is it will be more helpful than now I did my recent technique, because if you are beginners, please follow this technique. It's more safe. It takes some more times, but it's more safe. And you can see that full decompression is achieved like this. It's a bone surgery, yeah. And it's a post of MRIs and CTs. You can see the undercutting decompressed of the facet area, and full decompression of the foramen area is achieved. Here's my last slide. So it's my early stage patient result. The operation time is very reduced after 10 cases. So I think if you can do the lumbar surgery, try the cervical area, and maybe the learning curve, the point of your technique will be a 9 to 10 patient. And the BOSS score, look at the BOSS scores, very effective surgeries than the ACDF or AD or something for the unilateral radiating pain or upper extremity pain, radiating pain patient. So incision is so small, and there's less muscle damage and less bleeding, and only recovery is possible. So I very strongly recommend it to do the foramectomy with a UBE. Thank you for listening. I'll pass my mic to the Dr. Raj for the research review of the cervical anterior and posterior surgery. So please welcome the Dr. Raj again. Dr. Raj, please.
Thank you so much, Professor. That was terrific and amazing lecture. Beginners need to definitely understand how it's going about the cervical posterior approaches. With the surgical demonstration, definitely it will be helpful for the young spine surgeons and the beginners who want to start the UV surgeries. Very quickly and very shortly, we'll talk about one article which talks about the comparison of ACDF versus the posterior cervical foraminectomy. So, in terms of the success rate of the ACDF versus posterior foraminectomy, this article discusses about, it's a systematic review article, which it says that the success rate of ACDF is varying from 93% to 96%, while the success rate of the posterior cervical foraminectomy varies from 75% to as high as 100%. And there is no significant difference, statistical difference between in terms of the success rate and the pain relief in between the two groups. Also, there is, in terms of the range of motion, in ACDF, definitely when you see fuser, there won't be a range of motion expected. But at the adjacent segment, the range of motion of the adjacent segment in the ACDF group found to be much more than the PCF group, and which kind of led to the thinking that the increase in the range of motion at the adjacent level increases the adjacent level disease as well as degeneration. So the posterior cervical foramen anatomy found to be having less adjacent segment degeneration, as it doesn't have the instrumentation as well as the fusion, as well as the implant related complications with the ACDF were found to be a cage subsidence, cruise loosening, and the approach related complication in terms of the dysphagia, recurrent laryngeal palsy, hoarseness were found to be the anterior approaches, while the complications associated with the posterior approaches were found to be along with the UB with the irrigation techniques, the increase in the intracranial pressure due to the fluid retention, as well as headaches and dural tears and the fistula formation in the posterior cervical surgeries. Although few of the studies mention that the posterior cervical surgery has more of a axial neck pain, the recent literature, good body of research says that the axial neck pain is as equal as and not much statistically different than the anterior cervical spine surgeries. In terms of the cost effectiveness, Mansfield et al., Alvin et al., and Toomey Alan et al. Demonstrated that the cost effectiveness of the posterior cervical foramen surgeries over the ACDF varying from 39% to 89% in the cost effectiveness. The reoperation rate in the posterior cervical foramen, as the index level doesn't have the instrumentation or fusion, the chances of re-stenosis, chances of osteophyte formation, and need for the revision surgery at the same level was in earlier studies found to be higher. But the current literature mentions that the reoperation rates with the ACDF as well as the posterior cervical foramen is found to be same. The reoperation rate as per Wirth et al. Is found to be 27% with PCF at the 16-month follow-up. By Corinth et al. It found to be about 7.1% in the PCF group and 2.4% in the ACDF group at the long-term follow-up of 72 months. In terms of the complication rates of the ACDF found to be about mean complication rate 7%, while the 4% in the PCF group. And as we discussed, the complications including dysphagia, hematoma, hoarseness, recurrent laryngeal palsy, pseudoarthrosis, adjacent segment disease, wound infection with the ACDF group, while more of a hypostasia, wound infection, CSF fistula, intracranial pressure increase, headaches associated with the posterior spine cervical foramen anatomy. These are the few techniques discussed by systematic review. They discussed about the endoscopic percutaneous foramen anatomy, uniportal versus the biportal. It discusses both the techniques have similar results, just that biportal has less fluoroscopy time and reduced operative time. With that, we conclude today's session. We thank Professor Ha for having with us. We thank Mr. Jigu, Mr. Zhang Li, and after this we'll take the question and answer session. We also thank in between Professor Ha as well as Dr. Han Li from the Yonsei Hockey Hospital. We thank Yonsei Hockey Hospital for their cooperation. We thank Ortho TV, Dr. Ashok Sham, Dr. Neeraj Bijlani, Ortho TV team, Rishi and Ms. Poonam for their cooperation. And we now proceed with the question and answer session. We have Dr. Srinidhi who will be asking questions to Professor Han. Over to Dr. Ha again. Thank you.
Okay, Srinidhi, as a Q&A time, yeah. So,
Thank
any
you.
questions?
Yeah, thank you, Professor Ha. It was an excellent talk and amazing techniques. I just have one question, and I think I'll ask the question for all the beginners. You've done extensive amount of cervical as well as lumbar, so I would want to know, according to your suggestions or according to your experience, when is the right time for a spine surgeon who started doing UB on lumbar to venture into the field of cervical? And what if after choosing a time, what will be the first case or the type of case which I should approach for a posterior cervical?
Oh, it's very, very important and very important and good questions. Thank you, Dr. Srinidhi. There is nothing fixed the rule, but in my experience, I always recommend you that do cervical surgery after 100, at least 100 lumbar surgeries, because the surgical technique is not much different. The just ramiectomy and foraminectomy and discectomy is not different, but as you know, cervical is very smaller than the lumbar, and there is more neural tissues in there. So we have to be very careful and very technically surgery would be needed. So and the most important thing is we need to be ready to resolve the complication situation that we didn't expect it before the surgery, like a dural tear or massive bleeding, something, because that is more hazardous, more dangerous than the lumbar area. So if you prepare to do some confidence of the resolving some complications that we didn't expect it, something has occurred, then I will recommend them that is the time to do the cervical or thoracic spine. And second question is the first case. I recommend the first case is ipsilateral is more maybe easy for you because it is more familiar to us because we have so much tubular decompression, tubular cervical foraminectomy, the experience. So it's more familiar to us. So like all the articles say the minimum less than 50% of fastectomy is safe. So don't be afraid about the fastectomy anymore. So I strongly recommend the ipsilateral will be better for the first case decompression. Yeah. Thank you.
Thank you, Professor.
Thank you.
Okay, thank you. I will call Raj again. We'll finish this live stream of the Butterfly Show. Thank you. Thank you for listeners.
We once again thanks all the viewers across the globe, and thanks for the encouragement and sending the message that what improvements we can do and where we want which topics to be discussed. And we thank with full heart all the viewers of the Vertical View Show. Thank you very much.